Good afternoon and welcome. My name is Carrie Craven, Administrative Specialist for KCMPA, and we're so glad you were able to join us today. First off, we ask that while the webinar is in progress, you mute your phone lines to ensure that everyone can clearly hear the presentation. Please press star 6 on your phones to mute your lines. And if you have questions, you may ask it via the chat window, or we will open the phone lines up at the end for questions and answers. Joining me shortly is Cindy Campbell, Director of Clinical Strategies for KCMPA, and she will be discussing chronic care management. But first, I want to take a quick review of the upcoming webinar schedule. So we will be offering in December's the chronic care management, in January, end of life planning. February will be ACO quality majors for 2016. And then on March, the performance improvement. And in April, KCMPA, who are our members. May is open, and if you have any topics that you would like to have discussed or reviewed, we'd be happy to take suggestions at that time for the May webinar. So please feel free to share that information with Cindy, myself, or Jill Watson. All right, so Cindy, are you with me?
Yes, I am.
All right, turning it over to you.
Okay, great. Thank you so much. Good afternoon, everyone, and I want to thank everyone for joining us today to discuss this topic of chronic care management, or what it's also become known as is CCM. So to begin, you know what, Carrie? I think that this is the wrong set of slides. I'm sorry, I just noticed that. If everyone could just hold a minute while we pull up the slide presentation.
Cindy, I want to be sure I pulled the right ones because I pulled those from where I thought we had them stored the last time. Can you tell me exactly where they are hiding?
Let me go back and look at that. I apologize.
Sure.
I apologize. Let me. It's under the Dropbox, under the QI. And it's December Chronic Care Management. I have an updated one there. So I think for some reason it. So if you want to go in there and pull it now, or I can try to email it to you, or I can try to pull it up. Why don't I just pull it up?
Yeah, the only one I'm seeing is the December Chronic Care Management that was last updated on the 9th.
Okay, no, there's a new one in there. I think it takes a little time for it sometimes to show to everyone. So, okay. So if you want to make me presenter, I will.
I sure will.
Yeah, all right.
Okay, you are present now.
Okay, great. Thank you. I apologize, everyone. Sometimes we do some updates on documents, and it takes a little bit of time for the brain to actually make all the changes in the system. So, so once again, thank you for joining us for the chronic care management. And so we're going to begin today just talking a little bit about just giving an introduction to CCM and talking about the what and the why. So chronic care management encompasses this complete oversight and all these educational activities, all of these things that are conducted by the healthcare professionals to help patients with chronic conditions and with health conditions learn to understand their condition and how do they live successfully with it. And this all entails motivating those patients to engage in necessary types of activities and therapies, interventions that will help them to stay healthy, to get healthy and to stay healthy. And ultimately what we want is for them to stay out of the hospital and not have a need for these services at the acute level, but rather keep them in this nice quality of healthy living. So why is it so necessary that we start focusing on chronic care management? And according to the Centers for Medicare and Medicaid, 2/3 of the Medicare beneficiaries have at least 2 chronic conditions. And that's at least 21.4 million of beneficiaries. And then approximately 1 in 5 have a hospital admission per year at a cost of $100 billion. So we have a lot of sick patients out there with chronic illness that are going to the hospital. And then 98% of all hospital readmissions of those patients, they have at least 2 chronic conditions. So when we look at these numbers and at these statistics, we see why it's really important for us to start honing in on these patients that have multiple conditions, because they're really costly. So to give you a background on CCM, just talk a little bit about that, and I apologize, I'm going to try to put this into slideshow so it looks a little bit better there. Okay. Can everyone see that? Does that look fine, Carrie?
Yep.
Okay, great. So just a little bit of the background, because I think it's important to understand kind of where we're going with CCM. We need to understand where it began. So armed with these statistics, and not only these, but many more around chronic conditions and the health status of our older patients, our Medicare patients, part of the ACA was to create the Centers of Innovation by CMS, in which a number of projects were then deployed, and these projects would be working at the level of primary care. And these projects were constructed around encouraging, at the primary care level, improvement of care management of these chronic conditions, but not only improvement, but measuring outcomes and incentivizing for these outcomes. And then ultimately looking to see what happened. Did we have lower costs as well? Were the patients getting healthier? Did they have better outcomes? And did the cost lower? And a part of this project, these practices were given specific milestones that they had to achieve, and they were delivered at certain intervals and given time to meet these milestones. So a couple of those milestones were risk stratifying their patients. So they needed to go through their Medicare patients and apply a risk level based on their health status. And those patients that had, more chronic conditions and were the least unhealthy or the least healthy were given a higher risk status. And then they would take these higher risk patients and develop a care management program within the practice around these patients. So what we found was it was really taking a lot of different types of resources to deliver these care management services, and that it cost money and it was time consuming. So with that, based on that, then CMS decided to provide a method of being able to reimburse for care management so that it would encourage this further development of these programs and these processes within primary care. So it is now called CCM, or Chronic Care Management. It's CPT code 99490. It reimburses at approximately $38 to $40. We've seen that kind of flux simply because there's a few more kind of things that go into that specific dollar. So I'll talk about that here in a little bit. But just keep in mind that's what we've seen on average. And I've also had a couple of questions around the Complex Care Management Code, which is CPT 99487, and where does it play into the chronic care management services? I'm getting some feedback or some kind of a, are you hearing that?
I do hear the echo as well. If I could just make sure that everybody's muted their phone line, please. Either if you're on a landline, *6, or if you're on a cell phone, you can hit the mute button.
Okay, thank you. So what has happened is with the development of the CPT code 99490, it has replaced the 99487. And also just keep in mind that that 99487 wasn't just a specific code that was reimbursed, but it was kind of bundled in with multiple services, and so it was a little bit more difficult to kind of identify and pull this out. And so with that, having that recognition as well, the CCM 99490 was created. But I do want to kind of put this little note in there, a little postscript, that the private payers may still reimburse around the complex chronic care management. So it could be some type of a agreement that you have with one of your private payers, but that's not something that Medicare does reimburse at this time. So the CCM criteria, it has some very specific criteria in order to be reimbursed, and I'm going to go through these, and then I'm going to take each one and we'll break it down and we'll do a deep dive, simply because we get a lot of questions around, what do each one of these mean, and basically what do I need to do, what does CMS want for me to be able to get, or for my practice to get reimbursed for these services. So it has to be a minimum of at least 20 minutes of time per month that is engaged in care management activities. It needs to be performed by a clinical staff member, and when we say a clinical staff member, actually, you know what, I'm going to hold off. I'm going to go and do a really deep dive, so just kind of keep that in mind. It needs to be performed by a clinical staff member. It is a non-face-to-face, or it can be a face-to-face non-billable event, and we'll go into more specifics around that. And then the patient has to have at least 2 chronic conditions, and they must have a patient-centered care plan, a consent form for the CCM, and the patient has to have 24/7 access to their provider. And then electronic communication capability has to be in place within the practice. And then there is a cost-sharing requirement of $8, an $8 copay. Okay, so let's start doing a deep dive through all of those criteria that we have laid out on that slide. So first of all, time requirements. It needs to be at least a minimum of 20 minutes. The 20 minutes don't have to be all at one time, and it doesn't have to be all one person. It can be several people that have engaged in some type of a care management or care coordination activity with that patient in short increments of time, and then they can all be added up to be at least a minimum of 20 minutes. Often what you'll find is you have much longer time periods than that, but that is all that they require, at least a 20-minute time period. And you cannot bill for multiple 20-minute increments in a 1-month time per patient. So you can't, if you spent 60 minutes with a patient, you could not bill for 3 20-minute time periods for that patient. It would be 1 CCM reimbursement for that patient. And we'll have time for question and answer afterwards if you have more questions. So the next question that we get a lot is care management activities. What all does it entail? So I'm going to go over the next couple of slides and just talk about kind of in general what are some of the care management activities. Some of these you know very well and they're pretty obvious. Others it may be new to you, and some of them may sound a little bit redundant, but I just wanted to get a good feel for you understanding exactly what you can be doing in the practice that would fall under that care management bucket or into that bucket. So communication with patients, families, caregivers, or any other professionals or community services. So communication alone with any other entity that has to do with that patient and the care of that patient can fall into that into the care management bucket. So if you spend 10 minutes talking with a community service about arranging a service or some type of a resource for the patient, that can add as you're into your 20-minute time slot. Any time that you are spending on the care plan itself, so revising it, documenting it, implementing it, any of that time is considered time that can be added towards the CCM. Collection of health outcomes data and registry documentation. So if you are collecting health data that has to do with one of your CCM patients, that's also part of that time. Patient, family, caregiver, and education that will help support self-management and any of those things that we're doing, those discussions that we're engaging in that will help them to be active and complete activities of daily living will be part of care management. The medications, so reviewing their medications, doing medication management, and helping those patients to understand their medicine is part of their care management. Anything that we're doing as far as working with community and health resources that go towards that patient are part of it. Facilitating access to care and services that may be needed by the patient or the family. Management of care transitions that doesn't get reported as part of the actual transitions of care can be part of your care management. Ongoing review of your patient status, and that can include any lab reviews, other studies that you need to call the patient and go do a review. And as we know, those are not billable services, so that is something that can be added to the to your CCM time. And then, of course, documenting, communicating, reviewing that care plan is all part of the care management. Clinical staff. This is another question that we get that people have a lot of needs to know about. You know, who specifically is clinical staff members? What do they what do they require to be a clinical staff member? So it's really anything that is a registered nurse, licensed practical nurses, lab techs, radiology techs, medical assistants. And so really to kind of sum it up is any clinical personnel who cannot independently bill for their services alone. So as we see, this really takes no time. This service is not anything that is going to be a consumer of your provider time, because these activities really fall to that team, the clinical team around the patient at the clinic level. Some of the other clinical staff that are considered eligible to provide care management services are pharmacists. So if you utilize TRIA and TRIA does medication reconciliation, or if they do a comprehensive med review, that time can spend towards the 20 minutes. Also, meeting with a dietitian or the diabetic educator, and as long as these are not a billable event, then this time can be added to your CCM time. Okay, so when we talk about non-face-to-face, I know we see this a lot, and they really try to stress that these are those episodes where we're talking on the phone to the patient. We really have a lot of non-face-to-face engagement with these patients, and that's what they're really trying to stress. So this is any type of care management interaction that can be performed outside of a billable provider event. You cannot bill for a CCM on the same day as a billable provider event. So in this case, what we're saying is if the patient came in for a regularly scheduled appointment, that would then be billed for using another code, you could not think, okay, I'm going to call that patient today and we're going to work on their care plan. Or while the patient's here in the practice, I got them here, I'm going to work on their care plan and then bill them for CCM. That wouldn't be allowed. You would only be able to bill for that provider event. You can the next day call and then proceed to work on the care plan with them, and then you would be able to bill for CCM. There are also instances when you can, the CCM can be face-to-face, so but it's not in conjunction with another billable provider event. So an example of this would be if they come in to do a review of their, a diabetic comes in to do a review of their insulin and their glucose with the diabetic educator, and that's not a billable event itself, but it is something that has happened face-to-face that can also be put under the CCM. Okay, so chronic conditions. This is another one that we get a lot of questions. What really constitutes chronic conditions? What does CMS or Medicare want us to, what do they see as a chronic condition? And the good thing about this is that they do not specify to the practice what is a chronic condition of the patients. What their criteria is that it needs to be at least 2 conditions that are expected to last at least 12 months, place the patient at significant risk of death, acute exacerbation, or functional decline. So I've provided a list here of multiple chronic conditions, which can be included, but it's definitely not limited to. So those different things such as high blood pressure, high cholesterol, heart disease, arthritis. The other thing is obesity can also be a part of their chronic conditions. So I've listed them all out here. If you have any questions, please don't hesitate to send me an email, or we can even discuss it at the end of this webinar, and about any disease that is not on here, whether it would be considered a chronic condition. But one thing's just always keep in the back of your mind, is this a condition that would last at least 12 months? It places that patient at significant risk of death or acute exacerbation or a functional decline. So I think if you use kind of those little markers there, it does a pretty good job at guiding you. Patient-centered care plan. So the patient-centered care plan is something that I've also received a lot of questions about, what does it actually look like, and is it something that Medicare provides? Are there Medicare-sanctioned care plans? So I just want to lay that out here, that there are no specific Medicare-sanctioned care plans. However, they do have specific things that they would like to have included in the care plan. And those are things such as your problem list, expected outcomes and prognosis, any measurable treatment goals. And that's really going to be an important one, is what are the patient goals? So we really want to make sure that we outline those patient goals on there and outline how does the patient see themselves getting to those goals. Any symptom management, planned interventions, medication, anything that might be the community and social services, requirements for periodic review, and then, of course, your revision of the care plan so that the patient knows we're going to be looking at this care plan again on this date, and then we're going to be working together to revise it via what your needs are as those needs might change. The care plan should always be then provided to the provider and reviewed and signed off, and then provided to the patient as well. The patient typically can sign off if you see the patient face to face, or it can be given to the patient via the patient portal. And I just have an example here. I just pasted and copied a consent form. So when we talk about the patient must sign a consent form for the CCM services, this is a consent form that we have available and that we do utilize with various of the practices that do have a CCM program, and they're actively have the processes in place. And if you need a copy of this, or you'd like to see a copy of it, we do have one out on our website, or you can always send me an email. Provider access. So the requirement is that there should be a 24/7 access to the physician or any other of the qualified healthcare professionals or clinical staff that are that's including the providing patients and caregivers with a means to make contact with healthcare professionals in the practice to address urgent needs regardless of the time of day or week. Not time of day or the week. Sorry, I had an extra word in there. But really what this is meaning is that ultimately what we want to do is we want to address those patients' needs at that time if there might be a point in time where that their symptoms are exacerbating, or that they might end up in the ER or in the hospital, because ultimately we want to keep them out of the hospital. That's the ultimate goal. And so having them be able to get access to their provider quickly is the best thing to keep them out of the hospital. Electronic communication. So you must have the capability to electronically exchange any care records with other care providers. And this can include secure email. What they don't want to see is they don't want to see us printing and faxing. I think maybe having a secure fax system that is all electronically faxed is acceptable, but they are just trying to get away from printing off documents and, sending them in, those type of forms where it's a little bit more of a manual. We're trying to really move away from that. Cost sharing. So this seems to be the most debated piece of the CCM and the most discussed, and basically the providers, this causes them the most reluctance to do CCM because there is an $8 copay for these services. However, what we have seen is that in many cases the secondary is picking up this copay, and that the practices are not always requiring it to be done, which is fine. The one thing, just keep in mind, and if you are not requiring the copay for the CCM, make sure that you apply that rule to any of the other CCM patients that are receiving those services, and they might have a private payer. We haven't really seen private payers pick up on the CCM. That we probably will, but if you start seeing that, we just have to remember that if you're not making the Medicare patients pay the $8 CCM copay, that we have to make sure that we do that across the board, just to be in compliance. Reimbursement requirements. So there's just a few requirements around actually being able to get reimbursed, and that would be so only one provider is allowed to bill for each month. So you can't have the primary care and another specialist bill. It needs to be only the provider or one of those providers. Typically what we're going to see is it's going to be primary care. And this is one of the things whenever I talk about CCM, and I always get multiple questions about, well, what if the specialist does as well? What we find is specialists don't really know all of these types of codes. Specialists really focus around those codes that are specific for their area. That might change. We might see somebody, and I'm not saying that that's going to be 100% of the time, but that's typically what we see, and that this would be a code that we would see more specific to the primary care clinic. And it cannot be in junction with another billable visit on the same day, so we talked a little bit about that. The recommendation is to bill for CCM at the end of the month. So kind of, doing all of your CCM work, counting up your time at the end of the month, and ensuring that that patient has truly met the criteria. You have at least 20 minutes of time, and then billing for those patients. And then this is going to be a little questionable. When CCM came out, and I got this from the AAFP from one of their documents that came out in March, that services shouldn't be reported in addition to any TCM or home health care supervision and any hospice care supervision or end-stage renal disease. I'm a little bit leery if that is still true. I tell you there was a lot of things that came out early in 2015 just because everyone was being really pretty conservative around CCM because it was so new, and we just didn't know what would be denied. So I have actually sent an email prior to this webinar to get some clarification around that specific statement as to whether that is true, and I'm going to end up following up with this webinar, a statement, and provide some clarification on that. Okay, so with this code, we have certainly, and with most things, we see some challenges as well. We do know that it has been a little bit challenging for some of the practices to be able to implement some type of a CCM program. And what those challenges are that we're seeing so far are barriers and accelerators to adopting the program that has to do around program design, staffing, the technology, and then participation in alternative payment models. So it's been really difficult just around, what does this look like? How do we staff for this? How do we utilize the technology? And how do we, do we keep the care plans in the EHR? Does our EHR have that capability to create a care plan and then share it electronically? Does our EHR have the capability of recording all of the various time slots and capturing all of that time that would be attributed to each patient? there's challenges of physician engagement. Some of the physicians are, it's a really seems a little daunting, and so taking the extra or having to spend the extra resources that it requires, the time to engage in a CCM or a developed CCM process is a little bit prohibitive. And as well, patient education and engagement has been a challenge, just to get the patients to understand, that this is a need for them. This is a resource that is to help them stay healthier, to get the things that they need around their health and wellness. And then the actual time spent, so months billed, investments made, and expectations for economic return. So, once again, all of the time and the resources that we put into this, and are we going to be able to get that economic return? So with that said, I just wanted to kind of lay out there what KCMPA, what we see as a vision with CCM. We've done a pilot study, and we've had some good results as far as looking at the process, selecting those patients that would be good candidates for to be enrolled in the CCM program. And we've also done a pro forma for KCMPA, which shows that we have a potential revenue of approximately $3 million annually. And that is looking at all of our, especially our ACO clinics, and looking at our Medicare beneficiaries, and if we were able to capture 2/3 of those patients, it's not capturing all of them, but at least 2/3 of those patients that have chronic conditions, then that would be a very lucrative type of reimbursement. But also what we would want to see is not only the reimbursement, but what we want to see is that we would have improvement in our outcomes as well for some of these patients by really having a good developed program where we are actively working with these patients from month to month. So that pretty much ends my presentation on CCM and chronic care management services. And so does anyone have any questions?
There are not any questions in the chat, Cindy.
Okay. Well, that sounds great. I appreciate everyone's time today. And if you think of any questions, oh, I'm sorry. I do see a question in the chat box. I see lots of docs focused on the return of revenue, but not the outcomes. And, I think that is correct. I think because the fact that they're looking at the revenue and they're thinking, oh, all of this resources that we have to put into place in order to get this going, will we also have, what would be the ROI? And I think we have to just really keep putting that out there, that their ROI is, yes, they are getting some revenue, but they're also improving outcomes, which if we're having improved outcomes, that's going to lead to additional financial incentives as well. And so if we can kind of just keep focusing back on that, that this isn't just a way to make money, but this is a way for us to, be incentivized to perform these services and provide these services for these patients that are really the ones that we see as high dollar, and they're in the hospital. If we can just, keep them out of the hospital and attend to their needs, provide those resources, then you know, I think that overall that is a huge ROI. So thank you for that question or that statement. Okay, well, if we don't have any other questions, then I'm going to end my presentation, and if anyone wants to email me with any questions, please feel free at cindy.campbell@kcmetrophysicians.com. And our next webinar will be January 19th, and it's going to be on end-of-life planning. So thank you very much.